Welcome back to this next video in which we are discussing the drug treatment of essential hypertension. So in the previous video we studied the two categories of drugs that are used first line for the treatment of essential hypertension, namely ACE inhibitors and calcium channel blockers. And we saw how for people who are younger than 55 years of age and who are not Afro-Caribbean, the first line choice of drug would be an ACE inhibitor for the treatment of essential hypertension. And the classic example of an ACE inhibitor is ramipril. Alternatively, if the patient is greater than or equal to 55, or if they are Afro-Caribbean race, the first choice of drug should be a calcium channel blocker, and the classic example would be amlodipine. In this video, what we're now going to look at is what do you do if that doesn't work. So if you prescribe first-line therapy and their hypertension is still not under control, i.e. it's still over this threshold here, what do you then do? So the second thing to do is to double up, to go to dual therapy, to add on the one from the first-line therapy that you have not yet used. So let me make clear what I mean. Let's say we have a 49-year-old with essential hypertension who has been prescribed ramipril, brilliant, but their blood pressure is still not under control. It's still hypertensive, not so brilliant. What do you do then? Well, you would keep the ramipril, but you would add on a second drug, and that second drug would be from the class of calcium channel blockers. So you would add on most likely amlodipine. So you go to dual therapy, you double up. Alternatively, if you've got a 65-year-old who was given amlodipine for their essential hypertension but it's still not under control, then you would add on an ACE inhibitor, most likely ramipril. So you would double up. That's the second thing to do if it's not working. Let's now go to the third thing. What if dual therapy, double therapy, does not work? Oh, and just going back to double therapy, of course, if they had the side effect from the ACE inhibitor and then on an ARB, we consider that equivalent to the ACE inhibitor. So if we had a 49-year-old who had had a side effect from ramipril and had now been put on candesartan, but their blood pressure was still not under control, you would then add on amlodipine, just the same as if candesartan was an ACE inhibitor. So the ARBs are considered equivalent to the ACE inhibitors. The only difference is that you would only give someone an ARB if they weren't able to tolerate an ACE inhibitor. But as far as this algorithm for advancing treatment is concerned, the ARBs are considered equivalent to ACE inhibitors. So second line was going dual therapy, doubling up. What do you then do third line? Let's say they are on both an ACE inhibitor and a calcium channel blocker, or an ARB and a calcium channel blocker, but that is still not controlling their blood pressure. What would you do now? Well, at this point, you'd add on a third drug, and that third drug would be from a category of drugs known as the thiazides. So we'll put these here. Full name, the thiazide diuretics. And diuretic means that it's going to have an effect on the kidneys, it's going to make you produce more urine. So you may well already be guessing how these drugs are going to work. So let me give you two cardinal examples of thiazide diuretics. The major example would be bendrofluorothiazide, and generally the thiazides end in thiazide, which is very helpful. Another more archaic, rarer to see prescribed example would be hydrochlorothiazide, which illustrates again that it ends in thiazide. Another drug that we group together with the thiazides is indapamide, and you'll notice that that does not end in thiazide, and the reason is that it isn't, strictly speaking, a thiazide, because to be a thiazide you have to have a certain chemical structure. Indapamide does not have that chemical structure. However, we group it together with the thiazides because it works in the same way. Its biological target is the same as the thiazides. So we'll group indapamide in the group of thiazide diuretics because it makes more sense to group drugs according to their mechanism of action rather than their chemical structure. So bendrofluorothiazide and indapamide are in this third line treatment group here, and they work in the same way, and the way in which they work is that they increase urine production by the kidneys, and they work in a totally different way to the way the ACE inhibitors work. They don't interfere with the renin-angiotensin-aldosterone system. They interfere with the kidneys in different ways and just make the kidneys produce a greater volume of urine, so they make you need to go to the toilet a lot. But of course, by doing that, by making you produce more urine, they're going to reduce your blood volume, and as we previously discussed, if your blood volume goes down, then by Starling's law, your stroke volume goes down, and of course that means your cardiac output goes down, so your blood pressure goes down. So that is how thiazide diuretics are going to improve your blood pressure. And by the way, these two examples that I've given here, they are both commonly prescribed. So in indapamide, you do see this commonly prescribed. Bendroflumethiazide, if you're just going to learn one example of thiazide diuretic, that would be the absolute one to learn. But I don't feel that I can credibly not mention indapamide because it is a commonly used agent. So, third line therapy, what would you do? The patient's already on either an ACE inhibitor or an ARB plus a CCB. If their blood pressure is still not under control, you would add on one of the drugs from this category, either bendroflumethiazide or indapamide, most likely. So you'd go up to 3 drugs and hope that that is going to bring down their blood pressure. Now, all of what we have talked about so far is done usually by primary care providers. So in the UK, we call primary care providers general practitioners, GPs. In other countries, they're referred to differently, but I think the term primary care extends across a huge number of different countries. So your family doctor, your primary go-to for medical care, they would do all of this sort of treatment. They would start with the first line of either an ACE inhibitor or a CCB, then they would double up to dual therapy, and they might even go to triple therapy, adding on the thiazide. If we need to go further than that, if that combination of 3 drugs is not working, then you need to be referred to a hospital specialist usually. And the people in secondary care, and you'll either see someone who is a kidney specialist or you'll see someone who is a heart specialist. They will then prescribe the next line of therapy for essential hypertension. So the drugs that we have mentioned so far are primary care drugs. The drugs that we're going to go on to for the treatment of essential hypertension are more secondary care drugs. And the algorithm gets a bit messed up after this because it becomes much more whatever the doctor in secondary care wants to do. This is pretty standard, what we've said so far. This is what a primary care provider will aim to do. They'll start with monotherapy on either an ACE inhibitor or CCB, then they'll go to dual therapy of both of them combined together, and then they might even go up to triple therapy where you add on a thiazide. After that, when they've referred to a secondary care doctor, a hospital specialist, the hospital specialist will go to the other drugs, but with regards to which ones of the drugs that we've already got they will keep, that becomes much more whatever they feel like doing effectively. So they might keep some of the drugs that you've already been prescribed, but they'll slash others. They certainly wouldn't take you up to having 4 drugs. They get rid of some of the others before they prescribe the next drugs that I'm about to tell you. Okay, so let's now go on to these secondary care drugs. So other drugs that can be prescribed, and I'm going to write out all the categories first, and then we'll discuss them one by one. So one category is called alpha blockers, which are less famous than the beta blockers, which is another category. And then a very unfamous category of drugs are the Emac inhibitors. Emac inhibitors. And I'll give you examples of all of these 3 categories of drugs. So Emac inhibitors, firstly, this stands for epithelial, that's the E. Na is the periodic table symbol for sodium. C is channel, and then it's inhibitors, Emac inhibitors. Okay, so let's go back and start with alpha blockers. So there is one alpha blocker that is really used still in the UK, at least anyway, which is doxazosine. So if you're going to learn one, that's the one to learn, doxazosine. And this as I say, is a drug that would usually nowadays be initiated by a secondary care physician, and this is going to work by decreasing total peripheral resistance by making vascular smooth muscle cells relax. And I just want to talk a little bit more about this, because obviously we've seen a huge number of different drugs that make vascular smooth muscle cells relax and thereby reduce total peripheral resistance. So let's just talk a little bit more about vascular smooth muscle cells. So let's say that this is a little arteriole in some tissue here, and here we have a massively magnified up vascular smooth muscle cells. I'll just label this up. So VSMC, vascular smooth muscle cell. And remember, they're this sort of spindle shape. And of course, this is just one of them. You'd have a whole ring of them going around the lumen of the arteriole here. And thus, when they constrict, of course, the circumference of that ring of vascular smooth muscle cells will decrease, and therefore the diameter will decrease, and therefore the blood vessel will be constricted. So there are a huge number of things controlling the constriction status of vascular smooth muscle cells. A huge number of different receptors are on the surface of these cells and are influencing how constricted they're going to be. So let's just summarise some of the ones that we've seen. So let's take a piece of the membrane out of our vascular smooth muscle cell and put it over here. So let's say this is its cell membrane, and we'll just draw some of these receptors. So we have already seen the angiotensin receptor, which is an example of a G protein coupled receptor. So this can represent the angiotensin 2 receptor type 1. So A stands for angiotensin, the T stands for 2 because it's angiotensin 2 that is going to bind to this receptor, and the 1 labels the fact that this receptor is the type 1 receptor, and that's the receptor that is going to be on the surface of the vascular smooth muscle cells. It's also the receptor that is on the surface of the zona glomerulosa cells, which when it's activated by angiotensin 2 makes the zona glomerulosa cells release aldosterone. So that, when it is activated, increases the contraction of the vascular smooth muscle cells. So that's one thing that we've seen already. Now, another thing that I'm now going to add on is the alpha-1 receptor, which is a adrenaline receptor, an example of an adrenaline receptor. And these alpha blockers are going to be antagonists of the alpha-1 receptor. The ARBs that we discussed here, they are antagonists of the angiotensin 2 subtype 1 receptor. Both of these receptors are G protein coupled receptors. They have this 7 membrane spanning structure here, this serpentine structure in the cell membrane, and they both, if you know anything about pharmacology, if you don't worry about what I'm going to say, they both activate the GQ heterotrimeric G protein, and that through that pathway, they increase the contraction of the vascular smooth muscle cells. Now, just a little bit more information, which will become even more important for what we're going to discuss later. In all the arterioles in your body, you have these vascular smooth muscle cells with alpha-1 receptors on their surface, but what is actually stimulating the alpha-1 receptors? Well, it's going to be noradrenaline that is being released by sympathetic nervous system neurons. So that is what I'm trying to draw here. This is supposed to represent a postganglionic sympathetic nervous system neuron that is going to be releasing noradrenaline onto the vascular smooth muscle cells of the arterioles, and that is why the status of activation of the sympathetic nervous system influences the total peripheral resistance by influencing arteriole constriction. So this will release noradrenaline, which I'll abbreviate to NA. So these are two things controlling vascular smooth muscle cell contraction. Another thing that I'll just add on, and I think I'll change colour just to make it a little bit more interesting, is there are calcium channels, of course, in the cell membrane as well, and they are important. Their level of activation is important in controlling the entry of calcium into the cytoplasm, which also influences the contraction status of vascular smooth muscle cells. So this is a calcium channel here, and their level of activation will be dependent on the voltage across the cell membrane. the more depolarized it is, the more likely they are to be open, and therefore the more calcium they'll be allowing into the cytoplasm, and therefore the more contraction the vascular smooth muscle cell will be undertaking. So it's complicated. The thing controlling vascular smooth muscle cell contraction status is very complicated. Huge number of things influencing it that we've seen here. Angiotensin that's in the circulation, noradrenaline that's being released by postganglionic sympathetic nervous system neurons that go to all of the arterioles all over your body, and then these calcium channels. And of course, the calcium channel blockers, they worked by inhibiting these and thereby reducing calcium entry into the cytoplasm, and thereby reducing the drive to contract that is coming from the calcium channels. So all these different drugs, they're just targeting different signaling mechanisms on the vascular smooth muscle cells that are trying to get them to contract. So back to alpha blockers then. So the major example is doxazosine. They are antagonists of alpha receptors, in particular alpha-1 receptors. There is also an alpha-2 receptor. Doxazosine is a selective alpha-1 receptor blocker. So it would bind to this receptor, block noradrenaline from being able to bind, and thereby the alpha-1 receptor would not be activated, because this drug does not activate the receptor. It just binds to it and blocks the site that noradrenaline wants to bind to without activating the receptor, and therefore you would lose that drive to contract that is coming from the sympathetic nervous system. Therefore the vascular smooth muscle cells would relax, arterioles would dilate, and total peripheral resistance would go down, and blood pressure would go down. So that is alpha blockers. That's how they're going to bring down blood pressure. Beta blockers now. Beta blockers historically were very high up in the treatment for essential hypertension. They used to be pretty much first line. If you have high blood pressure, you'd be put on a beta blocker very, very quickly, whereas now they are much further down in the treatment ladder, and they're something that really hospital specialists should initiate the prescription of if it's being prescribed for blood pressure. Of course, beta blockers are still used first line for loads of other things, such as angina majorly, but for hypertension they're no longer used first line, they're much lower down. So examples of beta blockers. We are interested in the beta-1 selective beta blockers. So remember, there are 3 different beta receptors: beta-1, beta-2 and beta-3. We are interested in the blockers that just block beta-1. So let me give you some examples. The major example would be bisoprolol, but I'll give you 3 more examples as well. Metoprolol is another big example, and these are all beta-1 selective ones. Atenolol and nebivolol. And as you go along this list, they become less and less important for you to know. So if you're just going to learn one, learn bisoprolol. It is by far and away the most commonly prescribed, but you will see all of these 3 prescribed as well. So these block the beta-1 receptor. So they are not non-selective blockers, they are beta-1 selective beta blockers. And the beta-1 receptor is again a G protein coupled receptor. So if you wanted a picture of it, it would look just like this again. But they are not in the membrane of vascular smooth muscle cells. Instead, they are in the membrane of the cells that make up the heart. And they respond to noradrenaline that is being released by sympathetic nervous system neurons onto the heart. And by blocking the beta-1 receptor, you end up slowing the heart down and also reducing the force of contraction of the heart, because when the sympathetic nervous system is activated and releases noradrenaline onto the heart, and that activates beta-1 receptors on the surface of the heart, that increases the rate at which the heart contracts and also increases the force with which the heart contracts, and thereby increases cardiac output. Remember, let's just add up here on our equations. Cardiac output is equal to stroke volume times heart rate, which is plain common sense. Heart rate is how many times the heart beats in a minute. Stroke volume is how much it ejects with each beat. So if you times the 2 together, you'll get how much blood is being pushed around the body by the heart in a minute. So these will decrease both of these. They'll decrease heart rate and they'll also decrease stroke volume because they increase the force of the heart. They have a negative inotropic effect. Thus, they decrease cardiac output and therefore they decrease blood pressure. So that's how beta blockers, beta 1 selective beta blockers, are going to decrease blood pressure by antagonizing the beta 1 receptor of the heart, blocking the sympathetic nervous stimulation onto the heart, and thereby reducing heart rate and reducing inotropy. So those are the beta blockers. Then the Emac inhibitors. So these are quite rare drugs to see prescribed, but you do occasionally see them prescribed. Examples are amiloride and triamterene. And these are, in a way, similar to the thiazide diuretics. They are going to work by increasing the amount of urine that the kidneys are producing. They are diuretics, the Emac inhibitors. So they're going to increase the amount of urine that the kidneys are producing and thereby decrease blood volume. However, you'll remember when I talked about the thiazide diuretics, I said that they do not work by interfering with the renin-angiotensin-aldosterone system, and that was true. The Emac inhibitors, however, they actually do work on the part of the kidney that is affected by the renin-angiotensin-aldosterone system. So remember, this system influences the kidney production of urine, and it influences how much the volume of urine that the kidney is producing. The same bit of the kidney that is affected by this system is affected by these. So these actually inhibit the part of the kidney that will conserve water in response to the renin-angiotensin-aldosterone system being activated. So remember, when blood volume is low, so you need to conserve fluid, this system becomes activated and it acts on a certain part of the kidney, the distal convoluted tubule, if you know your nephrology. And it makes that part of the nephrons conserve fluid. These inhibit that part of the nephron from conserving fluid by blocking a sodium channel that is extremely important for that conservation of fluid. Thus, they effectively block the final portion of the renin-angiotensin-aldosterone system, but since they are just blocking the effect in the kidneys and not the effect on the vascular smooth muscle cells, they're just going to bring blood volume down. So it's not like the ACE inhibitors and the ARBs, which have the combined effect of lowering blood volume and lowering total peripheral resistance. These just lower blood volume because they just block the effect of the renin-angiotensin-aldosterone system in the kidneys. And of course, by lowering blood volume, you lower cardiac output by lowering stroke volume, and therefore blood pressure will come down. So these are hospital physician drugs. And as I tried to explain earlier, when you are sent to see a secondary care doctor, let's say you are on all three of the primary care drugs. So let's say you're on ramipril, amlodipine, and let's say benzoyl-thiazide. If you then come to see a hospital doctor, they will decide which one of these they would like to prescribe. So they might decide on doxazosine here. And when they decide to give that drug, they would not usually say, right, I'm just going to add this one on top of all the three that you've already got. So they wouldn't give you 4 drugs. They would probably cancel 1, maybe 2 of the ones that you're already on and prescribe you one of these secondary drugs. So you wouldn't just continuously add more and more drugs. You take other ones off and add on one of these ones. And which one you would add on and which ones you take off is really individualized to the patient and dependent on the physician that is prescribing them. But these are the drugs that are secondary care drugs that can be used if the primary care algorithm has failed to control the essential hypertension. Now, I've got a few more things that I want to talk about. One drug that rules them all, the one antihypertensive that, if all else fails, will work. And then I also want to talk about the drugs that are used in pregnancy to control essential hypertension, because most of these drugs that we've talked about so far cannot be used because they have detrimental effects on the developing baby. So let's start with the one drug to rule them all. So if everything has failed, if all of these secondary care drugs that we've just been through is not cutting it, there is one drug that is assured pretty much to work, and this is a drug called Minoxidil. And this works by opening potassium channels on the vascular smooth muscle cells. So now we have to add in even more onto our diagram over here. So let's just extend the membrane a bit. So the membranes become multicolored. So more channels in the cell membrane of the vascular smooth muscle cells here. So this is a potassium channel. So K is the symbol for potassium and C obviously is standing for channel. Minoxidil opens the potassium channels on the surface of vascular smooth muscle cells of arterioles of the body. By doing that, it allows potassium to move out of the cell. So remember, potassium is at a much higher concentration inside cells than outside cells. So when you open the channels, potassium will move out. When that happens, of course, you're moving positive charge from the inside to the outside. That will make the inside more negative and the outside more positive, which will make the electrical potential difference across the cell membrane even more negative, i.e. hyperpolarize the cell membrane. That will result in the closing of these voltage-gated calcium channels that we discussed earlier. Less calcium will be coming into the cytoplasm of the cell, and therefore the vascular smooth muscle cell will relax a little bit, it will contract less. So that is how minoxidil is going to make vascular smooth muscle cells relax. If you don't understand that mechanism, don't like electrophysiology, forget it. All you need to know is that minoxidil makes vascular smooth muscle cells relax. It makes all of your tiny little arterioles in your body dilate. Blood can then move out of the arterial system through those arterioles back into the venous system, and that's going to help reduce blood pressure down. So this is used for treatment-resistant hypertension. So TX like that stands for treatment. So treatment-resistant, and then the acronym for, or the shortened version of hypertension is HTN. So this is for treatment-resistant hypertension. Now, a warning about minoxidil. It ideally would not be given to women. It is usually a drug that is only used in men, and the reason it is not usually used in women is because it has the side effect of increasing hair growth. So generally, if women are put on minoxidil, they might start developing chest hair, tummy hair, more hair on the arms, more hair on the legs, and women don't like that. In men, on the other hand, men usually love this drug because it actually increases hair growth on the head. So men obviously suffer from androgenic alopecia as they get older, male pattern baldness. And this drug, to some extent, can reverse that. And indeed, it is actually sometimes used to treat male pattern baldness. And when it's used to treat male pattern baldness, it's usually used under the brand name Regain, as in regain your hair. So actually, the side effect of making you hairier is something that is actually looked upon favourably by men who take this drug, but obviously is something that may be intolerable to women who take this drug. So minoxidil is not usually prescribed to women, but it can be used for treatment-resistant hypertension in men. And it is a fantastic antihypertensive. It will bring blood pressure down brilliantly. Even if all the other drugs that you've tried have been miserably unsuccessful, this one usually will work. So it is very, very powerful drug. Okay, just to end this video then, let's just talk about what you do in pregnancy. So if a woman is pregnant, you cannot use any of the drugs that we have previously talked about because they cause horrible effects to the baby. In particular, the ones to be really, really scared of in pregnancy are ACE inhibitors and ARBs. The reason being that these interfere with this incredibly important system to the kidneys, and they can massively alter the development of the kidneys in the embryo. So you must not take ACE inhibitors or ARBs whilst pregnant, because you could end up with a baby that doesn't have properly functioning kidneys, and you can't live without properly functioning kidneys. It's not compatible with life. So pregnancy, we have 3 drugs that can be used to treat essential hypertension in pregnancy. So if you've got a lady who is of reproductive age, and who has essential hypertension and wants to have a baby, they need to be put on these drugs to control their essential hypertension whilst they are trying for a baby and whilst they are pregnant. So what are these drugs? So there are 3 of them. Labetalol, and they all work in completely different ways, all in completely different categories. It's a complete mismatch of drugs. Labetalol, an old drug, an ancient drug called methyldopa, and hydralazine. And these drugs, you'd really only see them being used for essential hypertension in someone who is pregnant. So let's start with labetalol. Labetalol is actually a beta blocker, but it is not a beta-1 selective beta blocker. It actually is a very wide-ranging blocker. It blocks alpha-1 receptors and beta-1 and beta-2 receptors. Now, it is still classed as a beta blocker rather than an alpha blocker, even though it does block alpha-1 receptors as well as the major 2 types of beta receptors. This obviously is going to have dual effect then. If it blocks the alpha-1 receptors, then it's going to work the same way as doxazosine works. It's going to decrease total peripheral resistance by relaxing the vascular smooth muscle cells. However, it's also going to block beta-1 receptors, so it's going to work the same way as all of our beta-1 selective beta blockers here. It's going to reduce heart rate and reduce stroke volume and thereby reduce cardiac output. So this is going to work in effectively covering both of these mechanisms here and thereby bring down blood pressure. And of course the significance here is it's safe to take in pregnancy, and it's a very, very effective antihypertensive in pregnancy. Methyldopa works by taming the sympathetic nervous system. It's a very strange little drug. It tames the sympathetic nervous system. So let's go back to the picture where we have a picture of a nerve of the sympathetic nervous system. So here we have the axon terminal of a postganglionic sympathetic nerve releasing noradrenaline here onto our vascular smooth muscle cell. Now, in the axon terminal, noradrenaline is manufactured and stored in vesicles ready for release. Methyldopa works by blocking the synthesis of noradrenaline in those axon terminals, and thereby it tames the sympathetic nervous system. So this is going to have dual effect as well. One, by reducing noradrenaline release onto the vascular smooth muscle cells of arterioles all around the body, it's thereby going to reduce contraction of vascular smooth muscle cells and thereby cause vasodilatation. So it's going to reduce total peripheral resistance. But 2, it's also going to have that same effect on the noradrenergic neurons that synapse onto the heart and release noradrenaline onto the heart. And thereby you're going to get less noradrenaline released onto the beta-1 receptors that are on the cardiomyocytes. Hence, it's also going to reduce heart rate and reduce inotropy of the heart. So it's going to reduce cardiac output. So again, it's going to have a dual effect. It's going to reduce cardiac output and reduce total peripheral resistance. So that's methyldopa. And again, it's a very effective antihypertensive, and it's really only used as an antihypertensive in pregnant women. Hydralazine is a drug that we do not really know how it works. What we do know is that it makes vascular smooth muscle cells relax, so again, it brings down total peripheral resistance and thereby brings down blood pressure. But apart from that, we can't really say much about how hydralazine works. So those are the 3 drugs that are safe to use as antihypertensives in pregnancy: labetalol, methyldopa, and hydralazine. The 2 that I see prescribed most commonly are labetalol and methyldopa. I'm not sure I've ever seen hydralazine prescribed, but in principle it can be prescribed in pregnancy. But you do see the other 2, labetalol and methyldopa, prescribed. So let me just recap what we've said in this video before we then end. So, first-line treatment for essential hypertension, ACE inhibitor or CCB, and it depends on your age and your race. Second line, you double up, you give both together. Third line, you add on a thiazide diuretic. That is what primary care physicians will usually do. If the essential hypertension is still not controlled, they will refer to a secondary care doctor, and the secondary care doctor has other drugs at their disposal. Here is our first category of drugs that they will turn to: alpha blockers, beta blockers, and Emac inhibitors, and it's really individualised to the patient what combination of drugs they're going to end up on, because they will not simply add on these drugs onto the 3 that they're already on. They'll cancel some of the other ones and add on 1 or more of these ones. If they are still failing to bring the hypertension under control, then in men they can go to the drug Minoxidil. They can use it in women if the woman doesn't mind the fact that it might make her very hairy, which is absolutely fantastic. If nothing else works, Minoxidil will work. It is categorically the best antihypertensive that we can use. And again, it's a secondary care drug. Primary care physicians, at least in the UK, are not allowed to prescribe Minoxidil, or are not allowed to initiate the prescription of Minoxidil. Then finally, we discussed the treatment of essential hypertension in pregnancy, and there are 3 major drugs that are antihypertensives that are safe in pregnancy: labetalol, methyldopa, and hydralazine. Thank you very much for watching this video. I hope that you've learned something.